Interactive case, high-altitude physiology and high-altitude pulmonary edema, HAPE. Case scenario, or our altitude's first expedition. For altitude, a young and ambitious physician has just joined an elite mountaineering medical team. His first assignment, accompanying a group of adventurers, including a 9-year-old boy named Timmy, to a high-altitude base camp in the Himalayas, altitude 4,500 meters. Everything is going well, but on the second night, Timmy starts feeling unwell. His father, a seasoned climber, wakes Dr. Altitude in the middle of the night with an urgent request. Question 1. What is your initial concern? A. Acute mountain sickness, AMS. B. High-altitude pulmonary edema, HAPE. C. Pneumonia. D. Simple exhaustion from climbing. Correct answer, B. High-altitude pulmonary edema, HAPE. While AMS is common, Timmy's cough, fast breathing, and worsening condition at night suggests something more serious. HAPE is a non-cardiogenic pulmonary edema caused by high-altitude hypoxia. Unlike pneumonia, it occurs without fever, though mild fever is possible, and it progresses rapidly. Timmy is at risk because he ascended quickly. He is a child, greater pulmonary vascular reactivity. He might have had a mild cold before the trip. Question 2. What is the underlying physiological cause of Timmy's symptoms? A. Decreased barometric pressure leading to alveolar hypoxia. B. Increased airway resistance due to cold air exposure. C. Hyperventilation leading to respiratory alkalosis. D. Low oxygen carrying capacity due to dehydration. Correct answer, A. Decreased barometric pressure leading to alveolar hypoxia. As altitude increases, barometric pressure drops, leading to a lower inspired partial pressure of oxygen, PiO2. This results in alveolar and arterial hypoxia, or tertiary eopakia, which triggers pulmonary vasoconstriction. In susceptible individuals, like Timmy, this vasoconstriction causes pulmonary hypertension, capillary leakage, and ultimately pulmonary edema, HAPE. Question 3. What physical exam findings would confirm your suspicion of HAPE? A. Crackles or rales on lung auscultation. B. Bilateral wheezing. C. Enlarged lymph nodes. D is a heart murmur. Correct answer, A. Crackles or rales on lung auscultation. HAPE is characterized by tachypnea, tachycardia, low oxygen saturation, crackles or rales cyanosis. Question 4. What is the most effective treatment for Timmy? A. Give fluids and keep him warm. B. Administer an inhaler and steroids. C. Immediate descent and supplemental oxygen. Start antibiotics for pneumonia. Correct answer, C. Immediate descent and supplemental oxygen. HAPE does not respond to inhalers, steroids, or antibiotics. The gold standard treatment is descent to a lower altitude. ASAP, even 300-500 milliliters can help. Supplemental oxygen to reduce pulmonary artery pressure. Hyperbaric therapy if descent is not immediately possible. Nifedipine or amlodipine for severe cases or prevention. Fluids should be given cautiously. Overhydration can worsen pulmonary edema. Bonus question. How can HAPE be prevented in future expeditions? A. Acclimatize slowly. B. Avoid rapid ascent. Consider prophylactic nifedipine or acetazolamide in high-risk individuals. All of the above. Correct answer, D. All of the above. Prevention strategies include slow ascent, no more than 300-500 mm increase per day. Rest days every few days at a high altitude. Avoiding overexertion and cold exposure. Consider prophylactic medication, nifedipine, acetazolamide, for high-risk individuals. Final decision. What should Dr. Altitude do? Dr. Altitude follows the protocol. Timmy is placed on supplemental oxygen. The team arranges for him to descend 500 meters to a lower altitude base camp. Within hours, his symptoms improve significantly.
That was scary, but at least I didn't have to take yucky medicine.